Hi, I'm Baskaran1. I'm a ENT consultant from Manchester. I've been given a rhinology top tips topic. I've chosen a random few topics. I hope you'll find this useful. The first, this video is only for education purpose. I'm sure you'll be sensible, won't share in any other platform. The first topic is the most common one, is the epistaxis. You may be given different scenarios, could be ward or A&E, but if you're given a topic, given this topic, just imagine yourself in that clinical scenario. Just start from the basic. Either you're a registrar or a consultant, just start from the basic, start from ABC. Make sure that make sure that the patient is hemodynamically stable. You may want to start some fluid resuscitation or blood transfusion if necessary. While you're resuscitating, you'll be taking short history from either from the patient or from the relatives, and your goal would be to identify whether is it a primary bleeding or a secondary bleeding, like was there any trauma or recent surgery. And also, you will explore in your short history about the common risk factors, like if the patient is on any anticoagulants. And while you're examining, you want to assess whether this is an anterior or a posterior bleed. If it's a minimal anterior bleeding, you can use vasoconstrictors like cofinocaine spray and identify where the bleeding point is. As you may know, more than 90% of the bleedings are anterior bleeding from the littles area. So if you can see that in a bleeding spot, you can cauterize it with a silver nitrate. And then you take it further. If the bleeding is excessive, uncontrollable, then you can use an anterior nasal packing. You can mention what your preference are in terms of packing material, a rapid rhino or a Mirocell or a ribbon gauze. If the bleeding persists and if you know that it's more of a posterior bleeding, then you want to consider for a postnasal packing. And again, explain what you're going to use. There are some postnasal catheters, posterior catheters are available, or you can use a urinary catheter. Just give them, what size you'll be using. You'll explain to the patient that it's going to be uncomfortable. Once you've inflated the urinary catheter in the postnasal space, and explain what material you're going to use. Commonly, you would use a ribbon gauze soaked in the Vaseline to pack the anterior nasal cavity, and mention that you'll be using like an umbilical cord clamp, and you'll use adequate padding between the ala of the nostril and the umbilical cord clamp, so that you're preventing any direct impact on the ala of the nostril. So if the bleeding is controlled, you'll admit the patient in the ward and monitor. If the bleeding persists, and if it's a posterior bleeding, you want to consider for surgical intervention. The SPL ligation, the sphenopalatine artery ligation is the most common surgical procedure. If a common surgical procedure that is performed, I think the examiner wants to know how you're going to do this procedure. So take them through that. You'll discuss this with your consultant. You will go through the consenting process. Patient under general anesthesia. You will examine the nose with the endoscope after removing the nasal packing, and then you can explain the surgical steps now. There are a couple of ways of doing it. Some would prefer to do like a large middle meatal antrostomy and identify the posterior edge of the maxillary antrum, and then you raise a mucoperichondrial flap, mucoperiosteal flap, or you can use like a ball probe to identify the posterior edge of the posterior edge of the maxillary antrum without doing an antrostomy. And then you can make a J-shaped incision, starting as high as the ground lamella and then coming down all the way into the inferior turbinate and then curving it posteriorly. It's important to identify the mucoperiosteal plane. Once you're in the plane, you can start raising the flap, and the next thing you would look for is the standard landmark is the crista ethmoidalis. So the artery is usually behind this crista ethmoidalis. As you may know, that often it can be like a one single large branch, or this artery can divide up to 2 to 10 branches, even in the pterygomaxillary fissure, and then it can come out through the bone. So it is important to identify each branch and cauterize it. Different techniques again used. Either you can use a liga clip, 2 liga clips, and then you can cut it in between, or you can do a diathermy and divide it, or you can use both as well. It depends on the surgeon's preference and whatever you're comfortable. The key thing is to identify the posterior septal artery branch. This is one of the commonest reasons why the SPL ligation fails. So it's important to identify, which will be at the anterior phase of the sphenoid sinus. So even if you can't identify, you just diathermy that spot, and hopefully that would address this posterior septal artery. The success rate is often more than 90%, and the earlier that you do, it reduces the hospital admission, and the patient can recover. Often you don't need to put any nasal packing. So when would you do anterior ethmoidal artery ligation? The typical history is usually a young male patient with a history of a trauma, and often they'll present with a brisk intermittent arterial bleed, often bleeding anteriorly despite using the nasal packing. So in those patients, I think if they're not responding to the nasal pack conservative management, then you would consider for anterior ethmoidal artery ligation. Again, you just take them through what you'll explain to the patient, consenting process, general anesthesia, and um, and then take them through the surgical steps, how you're going to ligate this artery. So the key thing is making a Lynch-Howard incision with an inverted V-shaped incision in the middle to avoid webbing, and identify the subperiosteal plane. And the next step would be to identify the anterior lacrimal crest. And then, as you may know, the rule of 24, 12, and 6. So from the anterior lacrimal crest, 24 millimeters, you will identify the anterior ethmoidal artery, and then 12 millimeter from there on, you'll see the posterior ethmoidal artery, and from there on, 6 millimeters, the optic nerve. The other important landmark is the frontoethmoidal suture line. So if you're not able to identify any of the landmark, just follow this suture line, and then you can often identify this artery. Again, the technique could be the safest thing would be to use liga clips, but if you're or if you want, you can use diathermy forceps as well. So the transcatheter arterial embolization is we don't do this often, but that's one of the technique that where you can control the epistaxis if all your other measures fail, like your packing, your surgical intervention is not controlling the epistaxis, then you may want to consider this embolization. Or if the patient has got multiple comorbidities and not an ideal candidate for general anesthesia surgery, then you want to consider embolization. So what they do is first they'll go through the femoral artery, do the angiogram first to identify the bleeding vessel, and then they use this different techniques, either PVA, gel foam, or coils to block the feeding vessel. I think it's important that a radiologist and as well as the ENT surgeon should discuss the pros and cons of the procedure. And one of the main risks are blindness, cerebrovascular accidents, or a false aneurysm at the site of the catheter insertion. So that needs to be, we need to go through the consenting process properly. So the second related and often a favorite topics for the examiner is hereditary hemorrhagic telangiectasia, commonly called as HHT. So sometimes they may show you this clinical photograph. You just want to explain. You could see obvious telangiectatic spots in the lips, perioral region, and in the tongue. Or if you do an endoscopic examination, you'll be able to see that in the nasal mucosa. So explain what is HHT. It's a genetic condition where there's an impairment of development of the blood vessel. So the blood vessel lose the contractile element. So it cannot stop, it cannot stop the bleeding when it's damaged. It's very rare. The incidence is 1 in 5,000. Although it's a congenital, often the patients are presented in their adulthood. Even I've seen patients who are coming, presenting even as late as 60 or 65. This may be the ENT, might be the first presentation with an epistaxis, and once it's a clinical diagnosis. Once you diagnose it clinically, and then you may need to investigate it further, which I'll come in next. There is, as you may know, that Koroko criteria is there. So you look at 4 aspects: the epistaxis, telangiectasia, visceral AV malformation, and family history. So if you have 3 or more, if they fit into 3 or more criteria, then it's a definite HHT. If it's a 2 criteria, it's possible or suspected, and it's unlikely if it is less than 2, if they fulfill less than 2 criteria. So in the investigation point of view, you want to do some blood tests if they've been having recurrent nosebleed, and look at their, and you want to check their hemoglobin level. And also the other investigations to see whether the patient has got any other visceral malformation, and even the other visceral malformations commonly could be in the brain, lungs, or liver in the GI tract. So you want to do an echo to find whether the patient has got any pulmonary AV shunts, MRI of the brain with and without contrast, and you can use ultrasound and the CT modality to check whether there is any AV malformation in the liver and the gut region. I think it's also important, we should refer them to genetic department for further genetic testing for the other family members. Stop. The management, there are two aspects of management. One is a medical and a surgical management. Medical management, we can use like a topical tranexamic acid or systemic tranexamic acid if the bleeding is heavier. We can use estrogen. The topical estrogen promotes squamous metaplasia, so thereby reducing the chance of recurrence of this telangiectatic spots. Beta blockers have been tried, and lately they've been using monoclonal antibodies like bevacizumab, which inhibits the vascular epithelial growth factor. There are a few trials which has come up and which has shown good benefit in patients with HHT. So the various other surgical modalities are there, like simple cauterization using bipolar forceps. In our center, we use KTP lasers. You can also use coablation and sclerotherapy. Septodermoplasty has been performed where they strip the mucosa and replace it with either partial or a full thickness skin graft. That the Young's procedure, as you may be aware of it, which is one of the oldest surgical technique, but it's often very effective, where they completely close the nasal, completely close the nostrils by using local skin and a mucosal flap, or you can use You can use a temporary nasal obturator to close the nostrils, and both techniques have been very useful and successful. I hope you like this video, and I'll see you in the next video. Thank you.